This is Bill O'Neill. I'm the medical director for the Center for Structural Heart Disease at Henry Ford Hospital and a practicing interventional cardiologist. This whole area of structural heart disease has been a radical redesign of the process of care for cardiac patients. Typically in the past there were two silos where the heart surgeon sat on one side and the cardiologist or interventional cardiologist sat on the other, and we kind of collaborated but not in any active way in terms of actual patient care. Now we're really blending these disciplines. First, the area where the doctors work, the hybrid lab, is a place that basically is structured to be able to perform full open heart surgeries if required, but also to have all the technological requirements for echo and non-invasive screening and catheterization. So that's the first change. The second change is that Medicare or CMS has mandated that both a cardiologist and a heart surgeon participate in these TAVR procedures that we're doing right now. And so we're actually working side by side. Initially it seemed sort of like a shotgun wedding, but as it evolved, the cardiologists and cardiac surgeons actually have a very good and collegial relationship. And I think the places where the structural heart programs involve a really good trust relationship between the cardiologist and the cardiac surgeon are the places where the procedure is going to prosper. Well, let's go backwards in time a little bit to what we were practicing between, say, 1980 and 2005. A cardiologist would see a patient complaining of chest pain. They would do the stress test. They would end up doing the cath and maybe have a heart surgeon kind of involved just as an ancillary. And then the cardiologist interventionalist would really drive the decision-making process about what treatment was to be offered. That's totally changed now with a patient that comes in with aortic stenosis. They're sent to us for evaluation for possible TAVR procedures. At the start, the cardiologist and the cardiac surgeon see the patients. And that's again driven by reimbursement, because we cannot do procedures on patients that are not considered high risk or inoperable. And the only person that can make that determination are the cardiac surgeons. So right from the very beginning, there has to be an active dialogue. Then we agree that the patient would qualify, they're high risk or inoperable. We put them through the screening. They get echoes and CT, and if they haven't had a cath, a heart cath, and then all of that information is collated in a structural heart meeting. It's a formal multidisciplinary meeting where the cardiologists, the non-invasive imagers, and the interventional and the cardiac surgeons get together. We then look at the patient and decide, first, is the patient a good candidate for this? Second, what would be the access? Is it technically feasible to do it? And then what would be the access? And half of the time the access is with a transfemoral approach, half of the time it's with either a transapical or a transaortic approach, which are basically formal surgical procedures. And so the thing that's really wonderful about this is that now, initially by force, but now by habit and by allowing us to sort of see an active dialogue, we really have gained a great deal in this collaborative approach. So we make the joint decision, is the patient a candidate? If the patient is a candidate, what is the route to take? And then we schedule the patient for the procedures. So it's really been a complete redesign and change in the process of care for cardiology patients in the last 5 years. Well, we haven't taken a formal approach yet for coronary artery disease management like we have for structural heart disease, but I think that the fruits of the labors of structural heart are going to translate into a much closer collaborative working relationship. I think in particular the fact that patients with multivessel disease are doing better with surgery than they are with stents are going to obligate us to have the cardiac surgeons much more actively involved. As you know, in the past, people kind of offhandedly called the interventional cardiologist the judge, jury, and executioner, because they would see the patient, they would decide on the cath, they would decide on whether they needed a stent, and then they would do the stent procedure without any kind of dialogue or interaction with other care professionals. Now, I think that's, especially for complicated coronary artery patients, I think this team approach or this partner approach that we've developed, I think, is really going to be a great additional benefit for the patients. Yes, so when we start deciding on whether the patients are candidate, first, are they high risk or inoperable? That's what CMS is reimbursing for. That has to be clearly documented. Cardiologist, cardiac surgeon both agree. So that's fine. Are they symptomatic? Do they have severe aortic stenosis? And those are all processes that need to be started. So once we kind of clinically decide that they're eligible for an intervention, then imaging is very important. We're doing either non-contrast CT or contrast CT images of the aorta and the lower extremities. And what we're getting with that is information on the annulus dimensions. That's becoming increasingly important because it seems as though we've been undersizing a lot of these valves in the first few years. And now with more advanced CT imaging, we're getting a much more accurate determination of the annulus dimension for sizing. And if you undersize the valve, you have a lot of aortic insufficiency, paravalvular leak. If you oversize the valve, you've got a risk of rupture. So that is really becoming increasingly important. The echo, so we combine the echo and the CT to decide on the annulus dimension. Then once we know what size of valve we need to put in, then the access becomes a problem. Unfortunately, the U.S. is really far behind on technology. We're 5 years behind Europe on the sizes of the valves, and more importantly, the dimension of the sheaths that are going to be required. So the current commercially available valve in the U.S. is the Edwards valve. For the transfemoral approach, we're using 24 or 26 French sheaths in the femoral arteries. That means that for the large valves, the patients need to have femoral arteries that are at least 8 millimeters in dimension, and for the smaller valves, they have to be 7 millimeters in dimension. Half of elderly women can't qualify because their vessels are too small. And so now either a transapical or transaortic approaches have been developed where the surgeons will do a small lateral thoracotomy to insert the valve through the left ventricle, or do a small J sternotomy to insert the valve through the aorta. So we can get the valve in almost all the patients. I've been experimenting with an old standby, the antegrade approach, where we actually can deliver the valves through a transeptal fashion, but that's just for a group of patients that have no other access. So we can usually find the access site by a combination of the CT and the echo, and then driven by that we'll decide the size of the valve, and then driven by the size of the valve we can decide on what the optimal approach is. So the lateral thoracotomy, I mean, basically that's just like an open heart operation. From what I can see, the patients often have a lot of chest pain post-procedure. A chest tube has to go in, and that really basically limits the patients. We've become very enamored with the transaortic approach. And the reason is that the surgeons can do a small J sternotomy. They're used to accessing the aorta. The aorta can be opened and closed with only a very small incision without chest tubes and actually without getting into the pericardial space. So the patients have no chest tube drainage and can be up and sitting the next day. So I think that in Europe, where they've got both approaches, people are sort of gravitating away from the transapical and more towards the transaortic approach. The other big problem with the transapical approach is that the surgeons have to do stitches on the myocardium, and the myocardium can be fragile. There have been cases where there's this term called sheep heart, where the ventricle is marbled and very fatty, and the surgical stitches just don't hold. And so those basically are contraindication. We can't figure out ahead of time by MR or CT or any other imaging who those patients might be. And there have been a couple of patients where we actually opened the chest and had to close because we knew that the myocardial stitches wouldn't hold. So I think all of those are kind of making people gravitate towards other approaches. The other two approaches that are potentially available, the left subclavian, that is okay for the core valve, because the sheath size for the core valve are much smaller. It doesn't work for the Edwards valve. One other approach that some French investigators and some doctors at Emory are doing right now are actually doing a cut down on the right common carotid artery, and then actually putting the device in through the common carotid into the aortic valve. So again, people are sort of trying to innovate or come up with other approaches, largely driven by the very large sheath sizes that currently exist with the current technology. Well, our center has gotten experience with aortic valves, and so we do see aortic surgeries. The place where we've seen an increase, we're currently participating in Partner 2, and in Partner 2, it's a randomized trial of surgical AVR versus TAVR for low-risk patients. So we have an 80-year-old person that's otherwise healthy. Their surgical risk is actually very low. The STS scores are around 3% for those people. We can't offer them a valve commercially available right now. The only way they could potentially get a valve is through the partner trial. So that has been a significant increase in the number of valve surgeries that our surgeons are doing. I think the finances of TAVR are fascinating and tricky. And I would go back to open heart versus stent. You know, if you have a patient that has 3-vessel disease and has a bypass operation, most hospitals make between $5,000 and $10,000 of profit on that surgery. Now, if you take that same patient and you put in 3 to 5 drug-eluting stents, they're going to lose $5,000. And so there's been a lot of places where, you know, cardiologists have been pressured to send the patients to open heart because it was a much more profitable procedure. I think there's going to be a similar sort of cost analysis. It's still a little too early. TAVR is a buzz. Every big medical center sort of as a point of pride wants to get involved with it. But the strict finances, I think, are going to become problematic. First of all, you have 2 physicians, a cardiologist and a cardiac surgeon, that are involved in about a 3-hour case. And those cases pay a split of a fee from CMS. And so on a strict basis, a surgeon or a cardiologist could do far more billable work on their own doing either cardiac surgery or interventional procedures. Secondly, you need to have a cardiac anesthesiologist, and third, you need to have an echocardiographer. So there are 4 physicians involved in a 3-hour procedure, and you're getting paid about 1.3 worth of physician effort for that. It's really unlikely that in private practice, with the current private practice mechanism, that any private practice physician would be able to make a living doing this. So I think that this is going to be centered in large academic centers where the cost and profit can kind of be splayed out more evenly. There are a lot of spin-offs, so the ancillary testing, echocardiograms, MRIs, CTs, cardiac caths, and then the imaging that's required for the follow-up, I think, is going to help offset some of the adverse reimbursement during hospitalization. A lot of it is going to be driven on how complicated the patients are. If the patient has a very simple procedure, we can get them out within 48 hours, and then the institution does make a profit. If the patients are in the hospital for 1 to 2 weeks, the hospital loses money, and then if they're in the hospital for greater than 3 weeks, the Medicare DRG for extreme cases takes over, and the hospitals do make some money. So there's going to be wild shifts in revenue. It still is very complicated. I think at the end, the numbers of places that do these are going to decrease just strictly because of the financial pressures.